so much. Thank you to the organizers for the opportunity to speak today. These are my disclosures. Relevant to this talk, I did receive investigator funding from Genentech and Regeneron for the studies that I'll be discussing. So radiation retinopathy can be a devastating side effect of an otherwise very effective treatment for potentially deadly disease, uveal melanoma. We know that the biology of this condition involves ischemia from the radiation and the damage it causes to the retinal blood vessels, upregulation of VEGF, significant macular edema, and ultimately, in its end stages, neovascularization and severe vision loss. In the past, many investigators have tried different approaches that have paralleled the development of different pharmacotherapeutics within the retina space. So everything from PRP to PDT, to intravitreal triamcinolone, to intravitreal dexamethasone, and even the use of silicon oil to attenuate the radiation signaling. These have all been done primarily in a retrospective context with variable treatment application approaches and follow-up. But the reality on the ground is that as anti-VEGF therapies have been developed in the retina space, these drugs have been used off-label in many patients, for many patients, for this problem as well as other rare problems. But an ongoing issue is that many patients cannot afford to continue this care, particularly when their insurance won't cover it, because it's not in on-label disease. So we identified that there was a real need for anti-VEGF therapy to be extended on the label for these drugs to help these patients. And so, following the footsteps of our retina colleagues, our team and others began working on prospective studies looking at the use of these drugs for radiation retinopathy, with the goal of getting the companies that make these drugs to extend the label to include these patients. Studies have been performed with both ranibizumab and aflibercept. The first study that was published was done by Ivana Kim and her colleagues at Mount Sinai several years ago, looking at the use of ranibizumab on a Q2 month schedule from the very time of proton beam therapy, so in a prophylactic type approach, and she found that there was a significant vision improvement over historical controls. Now, we won't have time to discuss all the findings of all these studies, but they've been done with both of these drugs in both a prophylactic and a sort of reactive strategy. I'll discuss briefly two of our studies that we've performed at our center. Our RRR study for ranibizumab for radiation retinopathy was a prospective study with 40 patients. There were 3 treatment groups for the first year, a monthly group with targeted PRP to ischemic areas, and a PRN group. At the 1-year mark, we found that the patients who had had monthly treatment, the most frequent injections, had a statistically significant improvement in their vision of 4 letters over the other groups. But then, in the 2nd year, when the trial flipped over to a treat and extend protocol, these benefits were reversed, and all 3 groups were back to their baseline vision. Now, this was still a significant improvement over historical controls, but it did appear that a treat and extend approach was not as effective. What we found with central macular thickness on the OCTs for these patients was that the PRN patients had kind of a sawtooth pattern in the first year, similar to what we see in the AMD literature, but a significant improvement in the OCT thickness in the first year, but in the 2nd year, the improvement was significantly decreased. We found, similar to the radiation retinopathy literature, that there was a significant decrease in the fundus findings related to retinopathy severity, with less than a third of patients showing fundus findings relevant to the retinopathy after a year. Of course, in this trial, as in other trials, there are really home runs that are wonderful for patients. Here's a patient in our ART trial, our aflibercept for radiation retinopathy trial, which is still enrolling. The patient started out with radiation maculopathy as well as optic neuropathy with significant macular edema in the upper left corner and a baseline vision of 2500. After 1 injection, the OCT is flatter, and by month 6, it's completely dry with a vision of 2050 maintained at a year with 2080 vision. And you can see that this tumor on the upper right was very close to both the optic nerve and the macula, and obviously a big improvement over historical controls. So questions for future studies, really the biggest question is, should we take a prophylactic approach or should we treat once we see clinically significant disease? This is a condition where we know these patients are going to have clinically significant findings. It's really not an if, but a when. Potentially, if we treat prophylactically, patients will have better long-term vision and maybe less anxiety about losing their vision, but disadvantages are important and may include cost or potential over-treatment. We've learned, certainly from the diabetic retinopathy literature, that anti-VEGF for prevention of progression is very effective, but there are issues related to cost effectiveness and long-term outcomes past 2 years, and certainly compliance. So my colleagues and I continue to work on this problem and to convince the drug companies to amend the label for these patients who are often very desperate We're working with the NIH and the DRCR on a much larger scale study as well as the industry. We're looking at longer acting agents once they're approved. And of course, if we're able to develop non-radioactive approaches, we may not even need to do any of this at all. Thank you so much.